All set. Okay, well, thanks for attending this morning. I'm going to present in the next 20 minutes or so a study that was funded by the Brain Foundation to Dr. Krigsman, started several, I'd say 3 years ago. And we're just now completing patient 25. So we have data on 25 patients that were followed longitudinally during standard of care, and in this case, standard of care would be a treatment of autistic enterocolitis, an IBD-like condition in kids with autism that's similar to but distinct from Crohn's and UC. Treatment following Crohn's disease-like paradigm. Typically, Arthur gives the first half of the talk, and then I give the second half where we talk about the data. So I borrowed a few slides from him. Hopefully I'll be able to do them justice. So this ASD-Associated Enterocolitis has been a topic and interest of his for a long time because the kids that he sees, and he's now, we banked samples from 1,500 kids over the last 20 years with autism and enterocolitis, confirmed enterocolitis. And it looks like Crohn's and ulcerative colitis, but it has distinct characteristics. So we published years ago a molecular study that demonstrated that. And so there is clearly overlap in all three of these IBD or IBD-like conditions, but there are also distinct characteristics. However, he has to treat in some fashion. So the way he has chosen to treat, his standard of care is the way you would manage a child with Crohn's disease. And these are just the standard characteristics of a child, symptoms of a child coming in for diagnostic workup, and you've seen this: constipation, diarrhea, abdominal pain, and other issues. But constipation, diarrhea, and abdominal pain, both in Arthur's practice and in the literature, are the predominant findings in children with autism who present to the gastroenterology clinic. And these are just some images of what he sees. So you can confirm this by identifying colitis actually during colonoscopy, hyperplasia in the terminal ileum, which by itself isn't diagnostic, but it's part of the bigger picture, and then histology. And I talked yesterday about how we're trying to confirm histologically that this is an IBD condition. So there's strong clinical cellular molecular evidence that this ASD enterocolitis is fundamentally distinct from Crohn's, yet there are overlapping characteristics. And again, that's why he chooses to treat these patients like you would treat pediatric Crohn's. So the immunopathologic nature of this enterocolitis is well established, and so he follows, again, a standard treatment regimen listed here. He would treat with immunomodulators, corticosteroids, immunosuppressants, anti-inflammatory agents, biologic agents, diet, etc. And so the treatment study that was funded by the Brain Foundation a couple years ago, the question I had for Arthur after having collaborated with him all this time and not being a clinician myself was, of all these patients that you see, who gets better and by how much do they get better on this regimen? I think that's kind of a fundamental question, because usually at meetings you see anecdotal stories of the ones that did really well and so forth. And the more fundamental question is, if this is going to be a standard of care treatment for this population, what's the real skinny on who gets better, and does it work for most kids? And I think that's the point of this study. It hadn't been documented before. And people like Dr. Krigsman, who's private practice clinician, just simply does not have time, unfortunately, to work this stuff up. He's got brilliant things in there for case reports and case series and all that, but it's just a matter of putting all that information together and presenting it. And I think it'd be highly beneficial, because he's probably one of the few people in the world that sees uniquely this population and so many of them, and exclusively this population, and all over the world, actually, all over the United States and all over the world. So the point of this study was to document quantitatively in a group of kids followed longitudinally during standard of care treatment for autistic enterocolitis, his term, changes in gastrointestinal symptoms, i.e. improvement, we hope, and then changes in ASD characteristics, because Arthur might argue, if he were here, that GI treatment is actually treatment for autism. So, the research question, does treating ASD-associated inflammatory bowel disease with these induction corticosteroids followed by maintenance therapy result in improvements in GI symptoms and cognition and behavior? The study design is as follows. We're going to measure, or we did measure, GI symptoms. There are several scales that the researchers use to evaluate GI symptoms. There's a GI symptom survey, there's a pediatric Crohn's disease index, and so there's several validated questionnaires. Arthur has felt for a long time that these are not entirely sufficient, partially because this population has unique characteristics. And so he developed 2 sets of gastrointestinal questionnaires that contain most of the information that you'll find in the already validated questionnaires, but they also have additional unique information, unique questions that would be identification of the characterization of unique features in kids with autism. So he developed 2 scales. We call them the bowel movement chart and the externalizing behavior scale, and I'll show you those in a minute. So these were developed de novo, just so you know. So when we go to publish this, there might be some pushback from the fact that these are not yet validated, but we'll deal with that when we need to. I think you'd find that they're pretty remarkable questionnaires in terms of directly targeting this population. Anyway, that's what we're going to use to evaluate the change in GI symptoms. So the kids that come in, they're evaluated at baseline, confirmed autistic enterocolitis based on ileocolonoscopy, and then they're enrolled in the study. And at that point, they answer the baseline questionnaires, and then we follow them for a year. And they're still under his care for the entire year. So each patient is an N of 1 and gets treatment based on what they respond to and how they respond. The GI questionnaires at Arthur's insistence were collected once a week for 52 weeks. So from a clinical trial standpoint, I thought that was pretty excessive because of, the parents are the ones obviously filling out the questionnaire, so I thought that was a lot. But he wanted to do that so that, the idea behind the concept was if you do that, then you can track individual changes in GI symptoms as you're doing the treatment, because obviously, you might imagine, not all kids respond in the same way and at the same rate. So if you have the clinical information in front of you, somebody has a flare or somebody's not responding to the steroid medication or somebody has other externalizing behaviors while on steroids that remits over time, you can track all that theoretically by looking at the questionnaire outcome data and track that with the clinical data. So we have the capability to be pretty granular with this. In this, what I'm going to show you today is just the broad overview. Oh, I guess I didn't mention we're also collecting ASD questionnaire data, and I guess that's kind of important for this study. So we're looking at, we're using 3 of the validated scales. Vineland is taken at intake and then at 12 months. The SRS scale is taken at baseline 6 months and 12 months. And then the autism behavior checklist is taken every 3 months, baseline 3, 6, 9, and 12 months. Because that's the most frequent one, baseline 3, 6, 9, and 12, what we did with the gastrointestinal symptom questionnaire data, even though it's collected every week, over 52 weeks, what I did is take the baseline 3, 6, 9, and 12-month cumulative data, because trying to analyze 52 weeks of data, we're not ready to do that just yet. And I don't think it's important. I think we want to see what tracks with what. So, again, the primary outcome measure are the changes in these scores. Now, when Arthur created the questionnaires, as a clinician, as you might expect, he just generated a bunch of cool questions that really are relevant. But in terms of how to score it, these are Likert scale questions, usually 0 to 7, answers and so forth. And some of the questions, if you answer 7, it means you've improved. And some of the way he worded the questions in the Likert scale, if you got a 0, that was a better score. So we tweaked the questionnaire now. So the point is, so we can have, like other questionnaires, a sort of a standardized scoring system, numeric system, so you know that if the number goes up overall, that means you show improvement, or if it goes down overall, you show improvement, depending. The other questionnaire have already been validated, and the scoring system has already been established. So, the first questionnaire is a bowel movement chart. We had 25 participants, and this is for all the questionnaires. We had 25 participants complete the 52-week study. I will say they did not all complete the parents didn't complete every questionnaire at every time point, but we have cumulative data, certainly before and after data, and then most of the data for the intermittent time point. So just to give you an example of these 52 questionnaires potentially that one patient could have answered, we got over 1,000 individual questionnaires from those 25 patients on the GI symptom score. We used a non-Wilcoxon signed rank test to compare data between the time points, and a P of 0.05 was considered significant. The data that I'm going to show you now, I'll be showing you side-by-side data for the next multiple slides. And basically on the left side is a bar chart that shows significant, or it shows the change between time points, and on the right side is actually the individual line graphs that show you individually did the patient go up or down. So, I'll get to that in a minute. The bowel movement chart has 17 questions, and they're divided pretty much into 5 domains: stooling behavior, stool characteristics, frequency of certain events, like, well, I'll show you. Bristol stool chart, and then finally another stool characteristic question. So this was just almost pre-association thought when Arthur created this questionnaire. We have retooled it so that it's scoreable now, but the original data on the first handful, and this held for the entire group, is if you look at the stooling behavior questions, what you see is on the x-axis for all of these charts is the weeks. And again, it will always be 1, 12, 34, 36, and 52. And then on the y-axis is the change in score. And so the bar chart, you can see that from baseline to 12 weeks, and then the baseline to 52 weeks, there's significant improvement. Now, again, this is just on the partial data. When I get to the summary data, that will be for all 25 patients. But the point is, most everybody improves. And one thing you'll notice in all of these, the improvement typically is found, significant improvement is seen at the first time point that we actually measure stuff, so at 12 weeks. They may be improving earlier, but I mean, what we're first capturing is 12 weeks. That's when we first get ASD data and the GI questionnaire data. And there's significant, highly significant improvement from baseline to 3 months. And then after that, it looks as though that improvement is sustained all the way out to a year. So there are very few cases where even on an individual basis that a patient does not continue to maintain the improvement. This is the second set of questions, and again, you see significant change at every time point all the way out to the end. And on the right, again, it gives you an idea, or gives you a sense of what individual patient data look like, because it's not a straight line. They don't go down and get better and then stay better in a straight line. It ebbs and flows depending on how they're responding to treatment. And obviously questionnaire data is somewhat subjective, and so there can be issues with that. But in general, what we see, the trends are that they get better within the first 3 months, and then they maintain that for the most part across all the patients. This is the final set of, or question 9 to 15. Again, significant improvement at every time point. Okay, the GI questionnaire data for the externalizing GI behaviors, and I have these questionnaires available, so those of you that might be interested to look at them, we'll be publishing those as an addendum to the paper, and it's going to be important for the field to look at those. And I don't know, I don't have experience with developing these questionnaires and then putting them out there before they've been validated at multiple sites. But I mean, we have to start somewhere, and so it's not completely an off-the-wall idea. That's how these other scales started, I'm sure. And they incorporate much of what's known about pediatric GI questionnaire data. So I think probably, I'm hoping we'll get positive feedback from these. Anyway, the externalizing GI questionnaire behavior, this is the stuff that you don't see on the standard pediatric GI questionnaire typically. And so Arthur thought it was really important to add this stuff in. And if you saw the individual questions, you understand what I mean. This one has 28 questions, 3 subscales. The first subscale looks at physical and behavioral signs. The second subscale looks at extremes of behavior, and then the third looks at measures of abdominal pain. And again, I won't go spend much time on this, but we see significant change in each of these subscales. And then here's the money shot. The composite scores now for the composite scores for the externalizing behavior now show a significant change, improvement. A lower score on this questionnaire means you're doing better. So there's significant improvement at 3 months and then every time point after that, comparing back to baseline. If you compare the time points each to each other, 3, 6, 9, and 12 months, there is no significant difference. In other words, they don't continue to get better after 3 months, but they maintain that high level of improvement, which is highly significant. If you look on the right, and this is a patient that was an outlier, you can see the outlier because the final time point is up at a very high score. When we did the original first 11 and presented that last year, and did the statistics, with that number 11 in there, it skewed the whole thing, so there was no significance. When you took that one patient out of the analysis, then everything was significant again. So I say that just to point out that a single point in a study that has a small n like this can really skew the data a little bit. But it also shows you that not 100% of everybody got better all the way across the board. I mean, that's the point of this, or the point of this exercise, is to demonstrate that as a group, most of these children get better based on this treatment, and the improvement is sustained over the course of at least 12 months. We might do like Dr. Adams and follow them. I mean, these are Arthur's patients, and so we may be able to have the ability to look at them 1 year further out and so on. Okay. The ASD questionnaires, I think most of you in the room are probably familiar with these, so I won't spend any time on them, but we had 109 individual ABC questionnaires, 70 SRS questionnaires, and then 50 VABS Vineland questionnaires. And we use the same statistic to compare since we're comparing within subject. And so the composite scores for the ABC checklist, again, you can see these track with the GI symptom improvement. Based on ABC, there was significant improvement at every time point. It may have gotten slightly better, or it might continue to improve over time because you have a P of 0.5 significance in 3 months, and then you have a P of 0.1 by 12 months. But at any rate, they got better within the first 3 months, and then this was maintained over the course of 12, and they may have even gotten a little bit better in some cases. The social responsive scale, same thing, improvement at 6 months, improvement at 12 months, sustained. The Vineland Adaptive Behavior Scale 2, in the case of the Vineland, a higher score demonstrates improvement. And so again, we have significant improvement, highly significant improvement, P001, at 12, from between baseline and 12 months. And then within the Vineland, there are 2 subscales that we pulled out because they're kind of relevant and they kind of track with what we found in the GI externalizing behavior questionnaire. So there's a maladaptive internalizing behavior subscale and also a maladaptive externalizing behavior subscale. And in both cases, so a lower score here means improvement, so the maladaptive behavior goes down. And so in both cases, between baseline and 12 months, the maladaptive behavior improves significantly, both internalizing and externalizing. And so in summary, these are the 2 GI scales side by side, and the data look pretty consistent in both scales. The improvement is apparent at 3 months and maintains all the way across the 12 months out. The ABC and SRS, same thing. This is the summary slide. You just saw the data. These are the VABS thing. Again, the VABS, overall VABS score gets better. The maladaptive externalizing and internalizing behavior also improve, as evidenced by lower scores. And so the take home from this, at least where we are right now, is it seems as though there's significant improvement both in gastrointestinal symptoms and coordinately autism characteristics based on 3 standard questionnaires that are used to evaluate autism characteristics. And so I think, I'll speak for Dr. Krigsman here, one of his thoughts is that especially if you reach and treat the younger children, that the GI treatment is maybe actually also a treatment for autism. And so I'll leave it at that. Thanks.
Thank you so much, Dr. Walker. That was a great presentation. And virtually, thank you to Dr. Krigsman as well.
Yeah. He'll be excited.
Yeah. Anyone has any questions?
So you just sort of alluded to it, but have you had any chance to analyze some of the subgroups, such as younger versus older ages? You have the plots that are there. Some look like they're great responders. Some look like they're poor responders. Have you had a chance to do